open and laparoscopic surgery. There is our case, it is a female patient, 22 years old, presented by segment 1, 8 by 8 by 8 centimeter, thin wall. We do it laparoscopy. It is 1 day only stay in the hospital. As say, there is our 5 board like laparoscopic cholecystectomy and another board for retraction of the liver. There is a 3 months after the operation, completely excision of the cyst. First of all, we do exploration of the abdominal cavity. Actually, there is a huge cyst in the caudate lobe. It is actually 10 by 10 centimeter, thin wall, agonizing pain, failed to improve by medical treatment. Serology is positive. You should avoid rupture of the cyst. You should avoid anaphylaxis so that we are prepared hypertonic saline 30%, and we must put a swab all around the cyst to prevent any spillage. The most difficult in this is the site of the cyst. It is in the caudate lobe. It is in hilum of the liver. It is in direct contact with the IVC portal vein. All this swab with hypertonic saline 30%. First of all, I enter by a needle to show that it is a HYDATID cyst and to show there is no pillary or vascular connection. IVC is posterior and portal vein and the hilum. Here I can't control the hilum of the liver because of the huge size of the cyst. After I am sure that it is a HYDATID cyst by its content from this needle, I aspirate. Management of HYDATID cyst include pericystic excision. Sure, there is no bile, no bleeding. Stools company have a metallic board 15, so I enter this metallic board totally trocar inside the cyst to aspirate all the content. After I am sure there is no vascular and no pillary connection, I follow with anesthesia to show no anaphylaxis. I have to excise completely of all the content inside the cyst. I inject the saline, hypertonic saline and betadine. To avoid recurrence, you should completely excise the cyst. It is considered in the past a contraindication because of thin wall, inaccessible site, relation to main bile duct and relation to portal vein and IVC. All the time, take care to avoid any spillage. Injection and aspiration, it is a one of treatment of the HYDATID cyst. Germinal layer and germinal membrane completely adherent to the wall of the cyst. Video. I continue. There is a cavity. It is actually a huge cavity with the germinal layer. There is the inside of the caudate lobe. I completely dissect. The germinal layer from the wall. Tips and tricks: avoid to be near to the wall to avoid the bleeding. One of intraoperative complication is the bleeding, is the distribution of the abdominal cavity, so that multiple operation like cystectomy, pericystectomy, partial cystectomy, hepatectomy, if it is localized. I continue to excise completely all the cavity and the content of the cyst and the larva and the germinal layer. Every now and then I put hypertonic saline and I put betadine and avoid contact with the internal wall of the cyst. Completely evacuation, then I will do a pericystectomy. It is a completely laparoscopic. As I said, it is considered in the past contraindicated caudate lobe, and the case in the caudate lobe is limited by laparoscopy. Completely excise all the content, and the posterior wall, there is actually the hilum of the liver and IVC. Avoid the bleeding. Be sure there is no connection with a major bile duct. Excise most of the wall of the cyst, and then I put the omentum in the remaining cavity. Thank you.